So, as you know, or I know I've met you years ago through Ed, um, and we had done I think we were talking to you about April 18th, which we used to call Sleep Apnea Awareness Day.
Yes, I
And
do remember that. I do remember sleep
as
apnea.
Carl and I have been working together hand in hand for the last 5 or 6 years, reinventing and evolving what a patient advocacy association should be, it occurred to us that we were marketing this the wrong way. It really, April 18th is CPAP Appreciation Day. This is the day you published. This is the day that you changed my life and that of a lot of other people's around us. And we want to recognize it for that. I should also tell you this happens to be my mother's birthday.
Oh, that's lovely. Okay.
So, and I can tell you it was harder to get a mask on her than it was on my, at that time, 4-year-old child. My daughter's
That's
now
right.
11, been treated successfully for almost 8, 9 years now with Dr. Gimeno and team out west.
Oh,
And
okay.
she's doing really well. And literally, just came back from her annual checkup from the pediatrician, and she's in her 85th percentile in height at 11 years old. And my
Oh,
wife
that's
and I
great.
are not the tallest people in the world. So
Yes.
I know we're doing something right.
And she's doing well.
She's thriving well. She's rarely sick. She's an only child, so she's a little bratty. But in school, on the athletic fields, she thrives everywhere she applies herself.
Oh, that's
Um,
wonderful.
so
So,
let me back up and say I would love to talk to you about where this all came from, and then hopefully let's see if we can wrap it up with where do you think it's going, and what are you seeing in sort of the innovation space? Those are my big questions from my perspective at this point of being an experienced patient. I'm sure Teresa and Carl have other things that they want to bring up or discuss maybe.
okay. Well, you're happy to record, and I'll try and not talk too much, but to talk about those three things. Where did it all come from? I did send a paper that I had published the end of last year in the American Review, which I gave a little bit of history. And I should say that I am continue to work like Christian, and one of my main interests is in children. So I continue to work very actively in the area of children, because one of my hopes is that if we can identify children like your own early, there's a better chance of getting a long-term cure. And that often is helping the growth of the upper airway, which I think many of you know about. And I know Christian Guilleminault and I both share a very strong desire to be able to identify early and to enhance the growth so that it lessens the need for the sort of treatments that we now use. So I first actually got to work in this area because I trained as a physician, but during that training I did research, and I was always interested in medical research. But after I trained as a pulmonologist, I went back to do research looking at breathing, but probably the main driver was to explore sudden infant death. Why did apparently normal babies die in their sleep? Although I haven't spoken much about it before, I think in this recent article I mentioned that, in fact, I'm sure that one of the reasons that I went down this path was that I'm sure my own mother died of sleep apnea. And because when I was a medical student, I was still living at home. I remember the night she died, that she had low thyroid function. In fact, she had that at the time of my birth, and it was on treatment. At the time, we didn't have the more modern thyroxines. They were using extracts, which were not very effective. Well, they were life-saving, but so she had actually, typical of women or men with long-standing myxedema, was quite overweight, and she had developed really quite marked snoring, so that my dad, actually slept in another room. So it's a familiar story. And in fact, I remember when over the few weeks, some time before she died, she was actually becoming much time, at the time we thought of it as fatigue, but with the glare of hindsight and training, I realized she was very sleepy, and it was very clear she had apneic events. And I remember the night she died, I woke up because even though I didn't usually wake up early, I woke up, but I remember it was 5 a.m. because I was woken by the fact that there was no noise. So that the lack of noise from the snoring sort of woke me. Obviously, I was in another bedroom, and I found her dead. And in fact, the GP, the practitioner who came, said, "Oh, it's obviously clearly a heart attack." I give you that background because I'm sure it was one of the reasons I became interested in, why did people die in their sleep? And then having trained in medicine, I remember when I was doing my specialty training, part of the specialty training was to read the latest literature. And I can still remember the day we found a classic article by Christian Guilleminault and Dement on patients with insomnia and sleep apnea. So that actually that was where I first found out about sleep apnea. So it was.
And we're still having that conversation these days.
Absolutely. All my fellows, I tell them to go back and read the old papers and don't just read the title. Go and read what's in there, and you'll see lots of things that seem to be neglected now. So that's actually an important background. So when I started working on my research years after specialty training, that was 73, 74, my supervisor at the time, David Reed, one of his very close friends rescued a baby, their own baby, and the baby was brain damaged. So he was very interested in sudden infant death. So that's how I got to start looking at, how do we breathe? And at the time, people were thinking, this babies are stopping breathing. No, that is the case. I don't talk a lot about this, but there's no question in my mind, one of the mechanisms of sudden infant death is upper airway obstruction and a failure of the baby to be able to cope with it, basically. Anyhow, at that time, we were thinking of an upper airway obstruction was one of the thoughts. And remarkably, there was absolutely no recognition of sleep apnea in adults at the time. In those, obviously, there are a few centres, and the Europeans started it. That's not quite true. I mean, there were episodic reports of this condition, but no one had any idea that it was actually so extensive as we know today. So that's sort of the background that I worked on. But then I actually I worked in Canada with a fellow called Elliot Phillipson, because he was looking at how breathing has changed in sleep. And then when I came back to Sydney, I was appointed back at what is one of the main university hospitals, Royal Prince Alfred. And my role there was as a respiratory doctor, was to look after people who had breathing problems, respiratory failure. And I went looking for sleep apnea. So I had to go and look for it because it wasn't there. So I think that just gives you a bit of a background to.
That's super helpful. Can I ask you this? Do you remember as a child your parents sleeping in separate beds, or did that happen?
No, they didn't. It happened much later. I don't recall the exact time, but it certainly wasn't when I was a child. But I think I do know the history. My mother had, I think I was the third pregnancy she had, and she developed the myxedema, or she probably had it around that time. And I know she was very sick at my birth, and then it was recognised she had myxedema. So it was, and that's fairly typical actually, that often develop, it's managed, but it's very hard to, it's much better now. But that's one of the things we found when I started working in this area. I found patients with myxedema and sleep apnea. They pretty well all get it. If you get low thyroid function, you get upper airway obstruction as well. And there used to be, what's interesting is that at the time, way back then, we were advised to be very careful of increasing the dose of thyroxine too quickly, because if you increase their metabolic rate very quickly, they could, people had experience of patients dying of heart arrhythmias. And what they didn't realize, of course, is that if you increase the dose of thyroxine and you don't treat the sleep apnea, you go from relatively mild desaturation to marked desaturation. And so that's all a bit of a
harm than good when we treat, and when we don't know the full story. But
well,
right?
I think that's the extraordinary thing about sleep apnea, is that it was hidden in plain sight. And I know that there is plenty of data about it increasing in prevalence and all the rest, but it's been with us forever. And there's no question that risk factors like putting on weight and other things bring it out and make it important. But one of the key mechanisms is the size and shape of your upper airway. It's not an abnormality. Some children do have, like Pierre-Robin sequence, they have a small airway, but so do lots of people have small airways. So I think that background, I don't want to talk too much about it, but I think that probably gives.
It's super helpful, and let me share with you. I mean, I was born in 1974, and I was one of those 10-month babies. So I guess they had my mom on so many drugs that when they went to deliver the first time, it was a false alarm. So I was 25 days later, past my due date, I was actually delivered. And I don't know if you can see on my arm, I still wear my dad's old medic alert bracelet.
Oh, yes. Yes.
And if I turn it over, it literally says, coronary bypass, 1975, memory loss, angioplast, 1993. He was, I think at 50 was diagnosed with what they said early Alzheimer's at that point. So the reason I'm telling you this is by the time I was in my 20s, I thought, I'd watched my father. I had 20 good years with him and then 10 bad years. And I really thought my life was going to be just dementia.
Yes.
Like, why even go through all this? You're not going to remember it all. I saw my dad forget everything. And so to fast forward a little bit, it was really just throwing caution in the wind with my wife, who really was my caretaker for all those years, because I wasn't diagnosed till I was about 35. And I was incrementally declining, but by having a baby, it saved not only my life, it saved my daughter's life, because then we knew what was wrong with her early on. And then I think it really, it sort of identified this family curse that we had, because we all looked alike.
Yes.
We all had this anatomical issues. So the story goes with me. At 2 years old, I had strabismus. Well, your eyes don't go wild unless they're not getting oxygen. So they fixed those at 13. Christian told me if I didn't have my tonsils and adenoids out at 2, my IQ would have been about 70 points lower by the time I got to puberty. I said, I didn't know my IQ could get any lower than it already is.
Yes.
So it's been between the countless car accidents, the failure to, why are you so smart, but you can't succeed in school. I mean, I am, because of you and because of this intervention, I've got a lease on life that if we didn't live in a modern world without electricity, and without some engineering know-how, I'm a dead man, and I knew that.
Yes. Yes.
And it's to be here 45 years later with you, with Teresa, who's been around from day one, Carl, who's one of the leading CPAP adherence doctors there is in the country and in the States, and it's just we're still dealing with CPAP, which is the best treatment right now. But because of the business side of it, we know that some of the innovation is being stifled. So I'm really excited about treating kids early and preventing a lot of this, but also treating there's a population that's this baby boom generation that's exponentially going into dementia issues.
Yes. Yes. Well, I think you wanted my comments about where it's going. Well, I think I will make a few comments about the CPAP and oral devices, as that there's no doubt that I think it's going to obviously play a major role going into the future. And the one, I shouldn't say one area, but the area about the technological advances and the masks and prongs that now have evolved really have made it so much better to manage. I use CPAP. I use CPAP every night myself. I have, and I look at my own airway, and there's no question I've got my mother's airway. And although I don't have, if I went for a sleep test, they'd say, oh, we wouldn't justify treatment because I don't have that dreaded AHI value, which I have been with Christian arguing, even though he invented it. I've been arguing against it for the last 40 years anyhow. However, but I do have runs of snoring, and I have one or two events, and that varies according, and I know if I use CPAP, and I'm treating my own snoring. And
at what point did you start treating yourself?
About 5 years ago. And I think I probably should have started a bit earlier, but what I've noticed, because I spend a lot of my time in my mornings, I spend reading and trying to write, and I know if I don't, if a night I haven't used it, I don't function the same way. However, that's partly because I'm tracked myself all the time, and I think that. So I think part of the problem we face with this is that that it is so common and it's part of so many different things. I think we greatly undertreat it and so that's slightly off the point. That what I was going to say is that I must have tried every mask, every device from the very beginning. And initially, when we started treating our first patients, who were always at the extreme end, as you know, the range here is people at the extreme end. The reason we could do it was because they were so sleepy. So it was almost like working with someone who was anaesthetized. And so when the patients, that was our experience, when the patients woke up the next morning and were wide awake, the question is, well, could we do it again tonight? And so most of that early work was driven by, those patients that we initially studied were all booked in for tracheotomy. And one of those first patients, having done the studies with the mask, said, I'm happy to use it at home. That's how it got going. I should comment here, I know I'm slightly off theme, but I'm very supportive of the patient groups because my whole, from the very beginning of this, I've always been worked with the patients, and it's the people who had the problem were key to it being recognised. We didn't get referrals from doctors. They were all from wives and husbands saying, my partner's struggling to breathe. And in fact, we spent, even though it became very clear, and even though groups like Christians and others were very aware of it, it was a real struggle to get our other professional colleagues to believe it was significant. So the patient groups were crucial to us being able to evolve the area.
Let me ask you this, for those original trach patients that you guys were doing, how have the long-term outcomes been for those patients over the years?
Well, very good. My first patient died a couple of years ago. He was in his late 70s and he'd been on it for 30 years. He died not from sleep apnea. He developed chronic myeloid leukemia. So he wasn't a sleep apnea, but he was a very interesting man because he was very successful. He ran a major company that operated through Australia and Southeast Asia, and and he couldn't continue. Had to leave because he was going to sleep during board meetings. But once we got him on treatment, he went back. He didn't go back to the same company, but he had a new company, and so he had a very productive 30 years, which he wouldn't have had. The others.
Did any of these trach patients then want to try CPAP after and just close up their hole, or was it?
Oh yes, absolutely. All of them did. No, we did. None of our patients. Once we had developed masks. Now, in the early days, it was hard going because we made all the masks ourselves. And one of the interesting areas of this is that the development of technology has been very critical. For instance, the development of electric motors, which are very powerful brushless DC motors, which are the basis of all these, and tiny motors, but with plenty of oomph. Design of the fan, and then the electronics that allowed it. So they weren't there then. The modern person doesn't realise that those things weren't there. So,
can you tell me, just going back in time in that sort of time machine, what it was like putting that first machine together? What made you come upon, say, I need to stent the airway open? What was the aha for you?
Well, I did. I was really trying to work out how we could study the problem, and we set up, of course, sleep labs. The initial sleep laboratories was in a cupboard area, and I had to travel. I went from one part of I had one room in one building and another room in another building, so we went to But so I was very actively studying what happens to breathing in sleep, and we were looking at patients with asthma, with all sorts of problems, and also trying to think about what it was. Why did people get upper airway obstruction? Now, there'd been work by John Remmers and Christian, etc., and we were still uncertain. Most of us thought it was actually the airway collapsing because of a combination of narrowness and loss of muscle tone. But some people still thought it might be active contraction. So there was a lot of discussion about that. And I was at the time thinking, well, how would I work that out? And I thought, well, if I could stent the airway with some pressure, if it was collapse and not active, it should be easy to keep it open. But it was not at all obvious. Well, how would you do that? So the problem was actually, how did you do the experiment? So I'd thought about the experiment, and so I should send you some photographs of some of the other. I had several research students working with me, and we used ourselves to do these experiments first. So we were testing, how do we measure breathing at night time? So I was thinking about that. However, even though I thought about, I thought about that as an experiment, it actually took me a year before I had a suitable patient, because in those days I had to look for the patients weren't there. And so I should tell you that I've always been very, my father was what was called an electrical fitter. He's an electrician, but he worked on shipping, in fact. So, for instance, during the Second World War, he was outfitting and working on damaged military naval vessels, etc. So he was always, I was the.
He was a picker.
Well, he worked. He's worked with his hands and thought and made things. And I've got two older brothers, and both of them were similarly. My eldest brother who's 8 years older, was always experimenting. We were doing things in those days you can't now do. You could go downtown and buy chemicals, which now you'd be arrested for. But I remember we would be doing experiments. It was very. So I was introduced to experiments as a child with two older brothers. Both of them became engineers. And so my wife says, oh, you're actually a human engineer. So I've
been a human guinea pig my whole life.
So it's true that I was actually very, and so that, in fact, when I trained in respiratory breathing, it is about measuring, measuring lung volumes and making circuits. So that background was very important for me to think about how do I make a circuit that someone could sleep on? That was the issue. I mean, don't be ridiculous. I mean, how could you sleep on something? So that's how it came about. But of course,
what were some of the first?
What was incredible, of course, is that we were seeing patients who are literally, because sleep apnea is essentially choking. You're choking multiple times a night. So here we were able to, with this was quite a sophisticated circuit, but very Heath Robinson with pipes. But there within a few minutes of getting a very gentle pressure, this person could breathe. It was exhilarating because, as you probably know, I mean, the patients I was dealing with, we were talking about people who we were in fear that they were going to die because they had such low oxygens, they had abnormal rhythms. So there was no question. And there were patients saying, look, Mr. Smith, we've really got to do a tracheotomy to keep you alive. So that was actually a critical part of it.
It's amazing you say that, because I don't know if I'd be here today having this conversation with you if I didn't have, when I went to UCSF to have my original sleep study, that I was so severe that they had a mask on me, within that first hour. And that next morning, I felt like I was reborn, and I ran home to my wife and I was like, this is amazing. And then to back up, the fact that I was allowed to leave a hospital setting without my intervention in hand is, in the States, is beyond ethical, but that's a whole other insurance issue we'll get to. But it changed my life. If I didn't have that first good experience, I don't know if I'd be here, but I was one of those severe. Christian said you had an AHI of probably 150 if you would have done a complete raw study.
That's right. Well, that was interesting that when we had to fight and struggle to develop a sleep lab in the hospital, and in all the time people would say, well, these people have walked into the hospital, they don't need a bed. But it was in fact, we could actually measure what was happening and then demonstrate, look, this person was going to levels of oxygen which are like going to the top of Mount Everest and back repeatedly. And look at the heart, and we were seeing, of course, terrible arrhythmias. And I would go with the records and show that to the head of the hospital and say, well, that's what we needed. So, in fact, what's really interesting, and it's very unusual, that the treatment, CPAP, actually played a really important role in actually helping us to show everyone that this was an important problem. And so when I was able to show, well, look, this is the patient without, and then we put them on this device and look what happens. That really convinced the hospital to say, oh, okay, we will actually help you do this work in the hospital. And that's what drove it. I think it did elsewhere too. But I think one of the interesting things about the whole CPAP story is that it's then allowed us to use it on a whole range of people who you wouldn't even think about doing a tracheotomy. And of course, that's how that's how Christian identified what he called the high upper airway resistance syndrome. And basically that's a syndrome where it's very, very mild sleep apnea if you're using the metric of AHI, but they can have very severe symptoms because of partial obstruction. Excuse me, I just have to shut the door.
Yeah, no worries. Carl, jump on in whenever you want.
Yeah,
sorry,
sure.
My door was open, sorry.
Yeah.
Go ahead. Carl wanted to ask you a question.
Oh, yeah. I had a couple of questions. Just in looking back from when you first invented it, through the 1980s and then into the early 90s, when did you first realize that it maybe was more common than you even might have first suspected? Because now we see the prevalence rates of, it's estimated upwards of 30 million in the United States, 950 million, almost a billion per ResMed worldwide. When did you realize it was maybe bigger than you even thought it was?
Well, it took a few years. What happened to us is that after the first, when we began to see patients, we had some publicity through the patients, and then we would see a few extra patients. But when we started to use the treatment, we again had publicity, and then the numbers we saw each year rose exponentially. So by about 1985, in 1982, 83, I thought we'd seen the entire number of patients with sleep apnea in Sydney, in Australia. Sydney's a fairly big city. But then 1985, each year, it doubled the numbers we were seeing. So by 1985, we were very aware that it was very common. Obviously didn't have any idea that how common it was here. We also, everyone knows about Terry Young's work with the first of the big epidemiologic studies, but we also started an epidemiology study in a very small but very representative town in Western Australia called Busselton. And we found in that, that was also published quite a long time ago, but that was by the end of the 1980s, we were aware that it was a very common problem. But as everyone knows, the more we see, the more we see. What I don't think people realise, and I think it's still an issue, is that almost every other condition you wish to think about, some degree of sleep disordered breathing is a contributor. For example, one of the areas that I've been pursuing very actively is pregnancy hypertension. Now, pretty well every woman who develops hypertension will have some degree of partial obstruction, and so and I think the other end of the spectrum, we know about from a number of epidemiologic studies, is that if you look at children in the age of 4 or 5, around 10% of both sexes have reported snoring. Now, as a group, they all have some degree of partial obstruction. So it's not a new disease, and I don't call it a disease. It's a disorder. It's part of being human. And yes, putting on weight's a huge issue. But if you look at the other end of the spectrum, there is now stronger and stronger evidence that it's contributing to the deterioration with people with Alzheimer's. Now, that was really years ago. There was some early data from San Diego from my good colleague there. But now the more recent data is indicating that, it's a mild degree, what we're regarded as mild disorder can have a huge impact. So if you look at any of the other common disorders, heart failure, hypertension, all of them. So the problem is not, and we still have it, a lot of clinicians think, there's this funny disease out there, a disorder, and they think of it as secondhand. One of the commonest problems as we all get older is the atrial fibrillation. Now, they all have sleep apnea, and the ones that don't have it are the snorers. So you'll say, using the AHI metric, they all 60, 70%. But if you look at the other 30, 40%, they're all having partial obstruction like I do, right?
It's just that we had these standards set, and so that's what we go by after all these years. I like we talk about who we're trying to advocate for. Is obviously we're trying to help our patients that are suffering with this now, but it's really the education for the moms, the grandmothers, to understand that if grandma's having dementia, let's go back to that. What happened in that third trimester of pregnancy?
Yes.
What happened to you? What happened to that baby in development? What happened postpartum? Cradle to grave.
That's right.
Syndrome, and it doesn't discriminate, doesn't matter socioeconomic. I don't think gender's an issue. Obviously, our environmental factors, air quality, and the food we're eating is leading to internal inflammation, which is not helping.
Yes.
But from a prevention, this was a disease, the way I've learned about it, in denial. My brothers wouldn't sleep in the same bedroom with me by the time I was 5 or 6.
Yes.
But the education wasn't there. They thought it was cute and funny. Nobody knew that there was
That's right.
wrong.
Well, I think actually that you bring on a very important point, is that when we started out, that's right, people thought it was a joke, that people made fun of it. And in fact, most people who had the problem would hide it. But the other thing is that people thought sleepiness equals laziness. So at least we've come a long way from that. One thing I was going to say, where is it going? Well, I do think we still have a big problem of recognition, still even among physicians. This is a very unusual problem because as a physician myself, I was very aware how negative and quite dismissive so many of my colleagues have been, and that's extended over years. And there's still a hint of it. Some people think, oh, I don't think this is not a legitimate problem. So, and we still have a bit of a problem there, because I think if you look at some of the publications that come out, that even though they're often as a reference to sleep apnea, it's very, very obvious that a lot of the people writing these papers don't actually know and are not actually experienced with it. I wanted to go on, where is it going? I do think there are good developments. I've spoken about the CPAP itself. The developments there are fantastic, and the modern machines that have been developed really make life much easier. I do think the oral devices can be very effective, but it's very individual. It's the individual response is very critical, and I do think you need someone to fit those devices properly. So that's a big area. The pacing, upper airway pacing, I think that has a future, and I'm sure that we'll get better. It's still a big deal in terms of getting it into place. There's no doubt that specific surgery works, and I think early on in life, I think rapid maxillary expansion, correct orthodontics. I think the myofascial training is actually going to is important, but these things need a lot of resources. I mean, I know in this part of the world, well, I'm sure in the US, having an orthodontist work on a child's airway is incredibly expensive. So, you've got college fees, and you've got college fees, and you've got orthodontist. So that's a real inhibitor.
I had to find a cleft palate doctor, surgeon in Florida, just because any other orthodontist, they thought I was nuts to bring my daughter to want to put a rapid palate expander in her at 3 years old when we first moved back here.
That's right. Well, that's also that's because, of course, the traditional use of those devices is focused on teeth, which is appropriately, whereas the focus on the airway is absolutely critical. A lot of the profession in that area are now becoming very aware of it, but it's still rather mixed in terms of the extent of knowledge. So I think those are issues. In terms of, there are some interesting medications that are evolving that do have some impact. My sense is that they're still a long way off, because one of the problems with any of the medications is, well, what are the downside? I think there are some extraordinary development in some areas of medicine, like some of the cancer therapies, where the immune therapy, you can identify the exact spot that you need to attack. We're a long way from that with sleep apnea, because it's not, I don't think sleep apnea is a disease. It's a function of being human and our upper airway needed for speech and development. One of the reasons I'm very interested in early development is that I think that I do think that there's a real issue about what happens in pregnancy, and I think that if the pregnancy is actually under stress, and like in hypertensive pressure, I think it actually has an impact on the fetus, and I think it promotes or reduces the development of the upper airway in the fetal stage. So there's a really important area there. I think one of the other big areas for this is that while the sleep area has relied very heavily on sleep testing, there are now technologies that allow us to measure this in a way which should be much cheaper, much easier for everyone. I mean, and so there's a big shift happening in the whole professional area that's, I think, going to happen over the next few years. People won't have to pay so much to have a sleep test to work out what's happening, for instance.
So let me let you catch your breath, and I'm sure Carl's got some more questions, but you had me thinking about something, and that's, this is a cradle to grave. We're evolving. The interventions are changing over the time. We acclimate to the pressure. I'm already, at 45 years old at the maximum pressure on a BiPAP. That's why now Casey Lee and I are talking about doing this transcatheter distraction and expanding it. Hopefully buy me another 20 years. Did you think in the early 80s that CPAP would have evolved beyond where it's at now, as far as how accurate, how precise, how dialed in it is, or the mask or the interface or anything like that?
Well, I think the developments have been phenomenal, and I think it's also a reflection of the whole, technological advances. So no, in the 1980s it was sort of a long way off. And I can be very frank that when we first started using it, I was thinking of it as a short-term therapy. So, and we were thinking that, and we continued to do so, and I still do, can I cure this? And so I always saw it giving us, getting the person back to good health and functional, and now allowing us to, in a very considered way, to look at, well, what surgery is going to work. And I still think that's the case. I think that I know some surgeons sort of think, oh, because CPAP has been so effective and used extensively that it's impeded the development of surgery. I don't think that's really true. I think that the problem is, and if you're going to have I've sent patients to California to have distraction done by the guys at Stanford, but it's a big deal. It's a huge deal. So that the problem is that you're going to be reluctant to do it unless you think, well, am I going to have a good enough result?
10 years ago, I wouldn't even consider an MMA. And that's what, now that he could do this and I can put on a BiPAP and post-op, that's what he told me. I was like, wow, yeah,
that's
sure.
Right. So there's an evolution of both areas. So I do think, I think those procedures will work, but you've got to. For me, talking to patients, I sent a number of patients to, I think Casey Lee did them, or one of the, or Riley did them. I'm not sure that he's still working, to California, but it was a huge deal to have that. I tended to do that in younger patients, obviously. I had a young woman I sent over there, and she got quite a good result, but it was a huge issue and very expensive. But I think that's still very important. And I think that particularly now we understand each of the elements that which part is it the structure, is it the size of this part of the area? It's a very complicated area for a surgeon to operate.
Multiple factors and variables that we have to understand before we can properly treat with the correct protocol, right?
Now, I'm aware that I'm going to have to stop in a few minutes, but I'm very happy to have further conversations like with you. This is actually, this is just so much better than Skype, which I've used, and obviously, and now I've got it. I still work within a university, and that's on their system. So it's obviously become very much a corporate tool, which is very easily available.
If you had some decks or some pictures, I could be sharing this while we're talking about it.
Okay.
Which is really cool too.
So I'm very happy to have more meetings like this, and I'm very happy to help your group in any way I can, because from my perspective, the patient groups, well, I have here spent, a lot of time and working with people, because it's what's driven the area. I mean, we wouldn't have done a fraction of what we've done without the patients really driving it and helping us. And one of the things that I'm aware of is that, for a person to have it, it's a very private matter, so that you don't really want to necessarily talk in a broad. It's your own private area, and I'm very sensitive to that. I was always sensitive to that with the many patients, but again, why I would rather talk to you as a group than the professional groups, frankly.
Well, quite honestly, Dr. Sullivan, we want to start talking with the guys that were the pioneers in this field, and helping us with your support. Go to the primary care physicians, the family physicians, the pediatricians, and start teaching them earlier about the education and the awareness, so that these things can be started treating earlier. I mean, if in med school that the doctors are only getting an hour or two of sleep education, and we know
it's still the case. It's still the case.
Which is still the case. I mean, sleep deprivation was a badge of honor. That's how traditional train, and that breaking that mindset is, we got to go way further upstream before you're going to change that thinking in a generation or two at least.
The other one comment I will make is that I still think, even though it's so important at the pediatric end, the pediatric end is very poorly supported, incredibly supported. And I can't, in all these years later, I still am sort of shocked at how poor it is. There are fabulous groups all over the place, but when it comes to out there in the rest of the world, it's very poorly supported. Part of that's the dynamic.
And I got to say, I mean, just one of the big things that jumps out at me watching my daughter evolve through grade school and preschool and all that is the kids that were presenting with the ADD or they're sick a lot or had the allergies. That protocol is put them on the Adderall, put them on the Ritalin, and without ever the sleep component being factored into the whole story. And you're affecting brain chemistry at an early age that you can't undo.
Yeah.
Well, Dr. Sullivan.
I know you need to go, but I think Teresa had a question.
I have just one very quick. You can do a quick answer on this.
Go ahead, Teresa.
3, 2, 1. I already read this a few decades ago, but a comment that you had made. And as a caregiver, I can totally relate to this. So I would just like for you to tell me how you personally felt when that first patient woke up and he felt wonderful. I have actually used this in my slides for education, but I want you to say it.
Oh, I was just, it was thrilling. I mean, as a doctor, I did come into the area to do medicine because I wanted to help people who are not well. So it was the most incredible experience. I feel, and I still, it hasn't changed. I feel very fortunate that I've been able to help people breathe, and to see the recovery is just miraculous. So,
and we are so grateful for you.
For eternity, I'm eternally grateful for what you conceptualized and the team that you put together and how you figured it out. I'm, like I said, we're literally not here having this conversation if that didn't come from your brain.
I should say that we were very lucky. There was a number of us, and I include my great friend Christian, a number of us working on the area, and that very active research group, that's where it came from. So I was fortunate to be able to put it together in that way and have that outcome. But I don't, as I say, I feel humbled by it, and I still feel the same response whenever I see someone get better. It is actually an amazing result, and I'm, as I say, I'm very humbled by it, but thrilled.
I can tell you, you know, for someone who didn't have, you know, who was a big dreamer and had a big imagination my whole life, I've physically and professionally have done more in the last 5-10 years than I did probably in the 30 before that because of this intervention. And I could not have done that without the support of the team and piecing this all together and connecting the dots. In hindsight, it all makes sense now, but because my baseline and my normal was what I was expecting, I never knew I had a problem. And I don't think most of society does.
But see, that outcome is phenomenal, really, isn't it? It's phenomenal to have that. So, well, let us speak again.